pulmonary edema, fluids that are entering into the alveoli. And so when you have this fluid, how are you supposed to do gas exchange? It's very difficult for oxygen to go through the blood as well as all this pulmonary fluid. So oxygen exchange is very poor in these areas, and they are also susceptible to infections as well. Okay. So here are the congested blood vessels. The capillaries are really wide. It kind of looks like a small artery because they're so big. So the dust cells, or not the dust cells, the heart failure cells are actually here. They're macrophages. They're similar to your dust cells, but instead of having carbon pigment, it's hemosiderin. So those are, try to look for that in the lab because we do have some nice slides on that. Right, infarction. Okay, so an area of ischemic necrosis, usually due to the occlusion of atrial or venous drainage. Okay, okay, there's red infarction. So I'll just go straight to the lab. What we have, do you know what organ this is? It is the testis, that's correct. All right. So the case that we have in the lab is testicular torsion. Okay? This is a normal testis though. I just want you to take a look at the color and the shape. That's a normal testis. Which actually has an appendage, but you don't need to know that. And do you remember your normal histology of the testis? They're composed of seminiferous tubules. Here they are. Okay? And you remember the cells there? You have your spermatogonia, your primaries, etc. Leydig. Okay, this is all normal. This is all normal. Let's go to the abnormal. Oh, it's still more normal. Sertoli cells with a prominent nucleolus. The nurse cells. Okay. Leydig cells. Okay, so what happens in testicular torsion? Usually, the most common cause of testicular torsion is what they have, what's known as a bell clasper or nutcracker anomaly. Okay? The way that the testis is arranged is a little bit different. So it's prone to being twisted more. Okay? So when the testis twists, that's also going to twist your pampiniform plexus as well as your testicular artery, therefore blocking the entry and exit of blood to the testis. This is considered a urological emergency because if you do not get it in the time limit, that testis will die. Okay? So here's what it looks like grossly. So notice that it's much more hemorrhagic. Okay? You no longer see the nice tan. Okay? You see where a lot of blood has been escaping. So they say the blue balls. Okay? We get this quite often sometimes. Histologically, what do you see? It actually depends on the severity. Okay? If it's still viable, you can still see the seminiferous tubules. But I think in our lab, it was beyond salvation. So in our lab, it's all dead. There's nothing left. And I'll show you the degree of severity. So here's the minor cases. In the very early cases, all you see is the blood vessels are really dilated. The seminiferous tubules are still alive and viable, so you can salvage that one. In more advanced cases, you start to see some of them are beginning to be necrotic. They're becoming pink. Although there are still a few viable, but there are some necrotic areas. Okay. And then this is the viable area with some cells. And then this is the one that we usually have in our lab. Everything's dead. What you see is coagulative necrosis. You see the shadowy outlines of where seminiferous tubules used to be. But again, all the cells are gone. But you can still see the outline. See the seminiferous tubule? It used to be here, but now it's all dead. So that is what we have in the lab. Very advanced case of testicular torsion. Okay? And for the last thing, almost done. I will show you this one in advance because technically my lecture on neoplasia is on Friday, but I think there's also a lab on Thursday which will cover neoplasia. So I have to also give you just the labs on neoplasia. Okay? So we have here a woman. What do you notice? Yeah, so if you look in between the shoulders, you see this little mass. Okay, so that mass had a soft, it was soft and it's mobile. On biopsy, it looks like this. Okay. And then histologically, it looks like this. What's your diagnosis? Your diagnosis? It's a lipoma. So this is a lipoma. A lipoma, is it benign or malignant? Benign. So lipoma is a benign tumor of fat cells. Now let me ask you, is this a well-differentiated or poorly differentiated tumor? And what does it mean when we say something is differentiated? So if we say something is well-differentiated, it means it resembles the normal counterpart. This really does look like normal adipose tissue. In fact, you would probably say there's nothing wrong with it if I didn't tell you that this was a mass growing on the back of something. If I told you this was the subcutaneous tissue, you could probably believe me. So this is a well-differentiated tumor. Okay? When something has no differentiation, meaning you cannot tell what it is, what do we call it? It's called anaplastic or anaplasia. When you have no idea what it is, that's usually a hallmark of malignancy. Okay? Well-differentiated tumors are usually benign, but there are some that are malignant. But when you have anaplasia, that's always malignant. Okay? We'll learn about neoplasia in my next lecture, but I just want to show you what we have in the lab. So lipoma, it is the most common soft tissue tumor in adults. You probably might even see patients with that. They're usually on the shoulders, back, and arms, okay? The tumor. Most of them are non-painful, they're not painful, except for one type of variant of lipoma, which is called an angiolipoma. This is a tumor of fat and blood vessels, and they tend to be painful. Most of the time, they're not. Okay? Next, we have another one. This one is actually going to arise from your salivary glands. So in this case, it's the parotid. Okay. This one is called a pleomorphic adenoma, or also known as a benign mixed tumor. Okay. It's called a benign mixed tumor because it's composed of two elements, epithelial tissue and then the mesenchyme or connective tissue. Okay. That's why it's called benign mixed tumor. So it usually presents as a slow growing, firm, mobile, painless mass. So here it is, this white area. And then when you look at it, the normal parotid gland is here. You can see the serous glands on the side. Do you remember? But you see this big pink, or pinkish light blue, that's the tumor. And within the tumor, there are two elements, the pale mesenchyme and the epithelial cells in there. Hence benign mixed tumor. And the way the epithelial cells are arranged, they're very, sometimes they're forming tubules, solid sheets, they're forming nests, like this, here. Ducts, okay. So you see the stroma, which is the pink, and you see the epithelium as well as myoepithelial cells. Those are the contractile muscles that surround it. Pleomorphic adenoma, that's benign. Here's another one. And again, another one. They come in different forms and shapes. Just try to look for the mixture. But some areas, they have maybe more epithelial and less mesenchymal, or even vice versa. So try to look at everything. Okay? So pleomorphic adenoma is the most common tumor of the salivary gland. Usually occurs in the parotid, and there's always those components: epithelial, myoepithelial, and mesenchyme. Right. Next one. Oh, this is always memorable. You know what organ this is? It's the diagnosis is a teratoma. Yeah. So we call this a mature cystic teratoma. Others call it a dermoid cyst because if you look at it, there's hair. And there's dermal appendages, and the lining epithelium is stratified squamous keratinized. And I actually really don't like this specimen because when you cut it, it's very oily and greasy, and then if you don't dispose of it properly, it clogs up the drain. So this is actually an ovary. Okay? The thing about this one is, this type of tumor gives rise to all three layers. So you can see any type of tissue in here. There's one that had retinal tissue, there's sometimes colonic, even nervous tissue. You can see many different types, but usually all of the cells should be mature because there's also an immature cystic teratoma. That's the malignant one, if it's immature. If it's mature, it's all mature type of tissue. So this is the dermoid cyst, okay? Ovary. Okay. Here's another one. This one had teeth, you can see. So there's some molars and hair. Okay. Do you know what it's called if it's all made of thyroid tissue? Struma overa. Okay. Well, you don't need to know that. I had one of those cases. In fact, she was hyperthyroid because of it. It was producing thyroid hormone. So yeah, this is a pretty interesting specimen, mature cystic teratoma or dermoid cyst. Okay. They are most common in young reproductive age women, like college students. Okay. They're usually a unilocular cyst with hair and sebaceous material. So it's like a lot of oil. Okay. Microscopically, keratinized stratified squamous epithelium together with structures, but you can find all the layers, cartilage, bone, thyroid, neural tissues, others. You can find anything. Here it is. So if I told you this is an ovary, you would probably say it doesn't look like an ovary because you see hair follicles. You see, these are cross sections of hair follicles. These are, what are surrounding the hair follicles? Those are sebaceous glands producing the sebum. Then we look at the lining epithelium, it's keratinized stratified squamous. So, dermoid cyst, mature cystic teratoma. Here's another one. Look at the lining epithelium here. Looks like it's small intestines. It's columnar with goblet cells. See the goblet cells? Goblet cells are not supposed to be in the ovary. You have a question? Yeah. Alright, so what are the signs and symptoms of mature cystic teratoma? If it's small, there's actually no symptoms. But what happens is sometimes they get big. So they have abdominal discomfort. Okay. They can feel it, and sometimes it pushes on their bladder, so they have urinary problems, and sometimes it can also cause dysmenorrhea. It varies though. Usually they have impressive symptoms. But good thing though that the mature cystic teratoma is benign. Although there is a danger that because the ovary has that cyst, sometimes it can also cause torsion. Similar to the testicular torsion, although now it's ovarian torsion. And that presents as really sharp pain on either side of the ovary. Very sharp pelvic pain. Yeah. Most of the time though, if they're small, they don't really always cause symptoms. But we get it removed once it gets bigger. Yeah. These are very interesting cases though, but I don't really like looking at it because it's very gross. Okay, more. There's adipose tissue. Okay. We see nerve tissues. These are nerve cross-sections of neurons, or nerve. So there's a lot you can find in them. The one that we have in the lab, it actually has some molars. But it's very old. It was still there when I was still a med student. Alright, so I think that's my last slide for today. Are there any questions?